Thanks, Eric. Again, acknowledgments again from Houston and Osam, and some of these slides are from him, and then from where I work now to some of the pictures. So, no disclosures. And, you know, the dialysis is a burden to the United States. I mean, probably around the world, right? 1 out of 10 Americans have some form of chronic kidney disease, which is estimated to be between 20 to 30 million people in the United States. More than 1 million have end-stage renal failure, and over 400,000 people are on hemodialysis, so it's a big deal. You know, there's the cost in billions of dollars from 98 to 2009. You don't see a trend downward, it's a trend upward. And so you're all going to be busy doing dialysis in your practice, whether or not you do it now in your fellowship. So as Eric and others have said, and Mal, you have to be ready to do this, because you don't come out of your fellowship thinking I'm just going to do nice big aneurysms and carotids and fem pops with gore above the knee. It doesn't work that way. Dialysis pays your bills, pays your retirement, pays your kids' school in private schools if you want to send them there. So you have to do that. But there are implications, right? So if the slide on the left shows you in the light blue, that's the cost of somebody being on hemodialysis. It's expensive compared to the transplant, which is the red group. And so on the red bar, and you can see there that the implication survival-wise is that if you have a kidney transplant, you're living longer. If you're on dialysis, you're not. And so it's up to us to keep the dialysis grafts and fistulas open until they can get a transplant. Unfortunately, don't come to Houston because it's a 5-year wait, right? But it's less in other places. The dialysis population's growing. It grows at about 7% per year. And correspondingly, access stenosis is a growing problem too. More access, more stenoses, because they don't stay open on a one-shot deal. How do they present? They can be asymptomatic, or they can present with manifestations of venous hypertension, or they can manifest themselves by hemodynamic clues on the hemodialysis machine. So what's the failure mode, right? If you're going to treat this, you have to know how they fail. Early failures are either inflow stenosis or failure of the vein to mature. Late in the general sense are outflow stenoses, stasis, and thrombosis. That's in a general sense without getting too specific. But you have to know those two modes. The etiology is usually neointimal hyperplasia at the venous anastomosis or at the venous outflow tract related to high flow states, high stress states, shear stress states, which is different than the carotid, right? Carotid bifurcation disease is based on low shear stress from Chris Zarin's and Seymour Gleikoff's data in the 80s, right? Central venous instrumentation is a cause for central venous obstruction. So the question is should we be surveilling these people then? Well, should we do weekly clinically monitored pulsatility, thrill, excessive bleeding, or should it be periodic surveillance, duplex? Should we be evaluating all these grafts every 6 months with duplex? The answer is no. There's two randomized studies from Moist and Robin which showed that the number of interventions done on the surveillance group far outweighed the ones where they're just clinical monitoring, but there was no improvement in terms of patency or number of interventions to maintain the patency or the number of grafts that actually went on to thrombosis, so it didn't help. So what do we treat? Well, we should treat significant stenoses if they cause symptoms. So there are also some trials that look at preemptive role. So if I have a significant stenosis, should I observe it or should I treat it preemptively? And again, Alan in '97, I think with Ruth Bush, looked at some data here, and they said, again, it doesn't offer any significant intervention regarding thrombosis or functional ability of the access. Okay. So what are the clinical findings that might lead you to do a fistulogram and then access angioplasty and PTA or stenting if necessary? Well, if clinically they come in and the dialysis says increased pulsatility, a pulsatility of the graft, dilated veins around the shoulder, progressive pseudoaneurysm enlargement, development of new pseudoaneurysms, progressive arm edema, face swelling, or prolonged bleeding from the puncture sites. How about hemodynamically? If they tell you that they've had elevated venous pressures on dialysis or increased pressures at a low flow rate of 200 milliliters per minute of a pressure of greater than 340 centimeters of water, urea circulation greater than 15%, and then you have your flow rates there. or if you actually have a decreased flow rate of more than 25% from one dialysis to the next. Where do the lesions occur? Primarily they occur at the venous anastomosis and the venous outflow tract, and you can see the numbers there. We won't belabor them. We have to get through some slides, get to the pictures. So how do we intervene on a symptomatic, clinically important access stenosis? Well, we either balloon, we balloon along with a bare metal stent, or we balloon with a covered stent, or we use a cutting balloon. There's probably as many different opinions how to treat this as there are a number of dialysis patients, and I'm interested in Eric's opinion about this. So several studies show that there's no advantage for primary stenting at the venous anastomosis, all right, as opposed to balloon angioplasty alone. And the global response is that we should only use stenting when there's suboptimal result to an angioplasty alone or when there's rapid recurrence. I know in my practice, though, they don't do it after one. If a restenosis occurs after one dilatation, they'll keep ballooning it because their philosophy is we don't want to put a stent in a patient. Again, I'm not sure that's agreed upon nationally or in other places, but it's the way the practice where I'm actually working now works. So how about sometimes you put a coil in because the fistula isn't maturing because you have side branches, and so that's going to require an angioplasty. So that would be an indication. And you can see there that you've basically, on this fistula, you're able to actually dilate the more proximal area. Somebody who presents with low flow during dialysis, they just can't get the flow up. And you can see that the distal aspect of that graft is diseased, and so we had to balloon dilate that entire thing, including the anastomosis. How about cephalic vein outflow stenosis? You can see, let's see, where's the pointer? You can see here that the cephalic arch is diseased here, so we just went ahead and ballooned that, and you have a nice little result there. Now, if that was to come back multiple times, we'd probably try and balloon that, but at some point we'd have to do a cephalic vein turn down and take this cephalic vein and bring it more proximal to the axillary vein. So the other site that we typically see is an axillary vein stenosis, and you can see here that the actual stenosis does include part of the anastomosis, but tends for the next 7 to 10 centimeters of the axillary vein. You can see wasting there as it's getting to full profile, and you have a reasonably good result. For those of you who do lots of arterial angioplasty and stenting, the results after venous angioplasty and stenting isn't always fulfilling. It doesn't always look perfect, right? You know, and you're not always going to be perfect, but you want to get them to the next dialysis moment as quickly as possible. That's the goal. You can do it centrally, and you're going to use much larger balloons in the central system, 12 by 4 centimeters, 14 by 4. And surprisingly, the veins are pretty resistant, and the risk for rupture is pretty low. Here's a typical assessment of an innominate vein stenosis, also a subclavian here. Balloon angioplasty with the 14 by 4 balloon with a pretty good wasting. And that's the result, not bad. So what's the difference between these two? Which is what you look for when you do this. And again, here's another repeat because they thought that wasn't good enough. But it's right here, right? These collaterals were present pre-balloon. They're no longer present post-balloon. I hope it works, yeah. Good. Here's another one where you have an innominate vein occlusion without a thrombosis, right? So you get through this occlusion. You don't have to do any rheolytic or pulse spray because there's no thrombus there, but you need to get the wire, and you may have to exchange from a glide to a stiff to support it. You may even have to go over the catheter, and you get your balloon to dilate it, and you can reopen those occlusions, but you have to make sure that there's no thrombus if you can, all right? So that takes some doing. And then Eric went over the hero, so I'm not really going to go over that too much, but it's actually quite nice when you have a central stenosis that you can no longer angioplasty, not a stent candidate, just as not a viable option, and you can use the hero graft to actually overcome those areas that are no longer amenable to a percutaneous approach, and it actually works quite well. Here's an example of stenting, right? We've dilated, oops, oh no, where am I going? So we've dilated this multiple times, didn't work. We had a stent already in the outflow, and you can see here we had to re-stent this area to make sure that it stayed open. So there are indications for stenting in this area. How about in the femoral artery? Here's an occlusion. In the femoral loop graft, we dilate it up. We have a reasonable result, still not great. There's still residual stenosis, and we had to go to a larger balloon with prolonged inflation times. The difference in venous is that you have to inflate for really 1, 2, 3, 4 minutes at a time, not the 30 seconds up and down like an arterial. All right? Covered stents, Viabond, fluency, flare, and the wall graft. These are just as an old picture, but just basically give you a sense. All of you know what covered stents look like, or you should. You can use them in multiple, and I don't want to get into this because I think the speaker after me is talking about pseudoaneurysms, erosions, but sometimes you can get erosions of a fistula where, and you're also associated with a stenosis here, but you can see that that's actually going to leak into the skin, and so you've got to cover that area and use a covered stent that takes care of that so it doesn't erode through the skin. Here's another one, it's erosion without a pseudoaneurysm, same thing. You've got, again, this area, I'm not going to belabor it too much because I think the next speaker is going to talk, but you get a covered stent and they can actually be stuck. The flare and the fluency are easier to stick for the hemodialysis technicians than it is for the Viabond, if it's in the area. Here's an example of a femoral loop, again with a pseudoaneurysm. We put a covered stent in there and that's fine. So how about covered stents of the randomized trial by Ziv Haskell in 2010 in the New England Journal of Medicine, 190 patients with venous anastomosis stenosis, PTA versus PTA and stent graft, 6 months primary patency. They found that the patency was much greater with a stent graft for recurrent stenosis. Freedom from future interventions was less with PTA and stent graft versus PTA alone, and the stenosis binary restenosis was less as well. Adverse events were equivalent out to 6 months. Again, here's another example of a mass at the anastomosis and just beyond, so a covered stent. I want to move through. This is a case that I did about 2 days before I came where he had a clotted graft, and we had residual thrombus in a dilated segment. And what we did is I went ahead and put a flare stent in there, which covered it quite nicely here. So how about the thrombosed AVF? I only got 30 seconds, but we call them cleaners, macerators, compressors, sweepers, dissolvers, pulsers, and scrubbers. There are lots of techniques to take care of this that they have to do with balloon angioplasty, lysis, real lysis, mechanical thrombectomy, endovascular stenting, endovascular stent grafting, and knowing on your thrombosis, so I got 8 seconds, venous graft is thread thrombus, arterial is usually white. There's a typical picture. These are typically the steps. Oh, and I think I'm done. Sorry, anyway, so the thing you need to realize, and I'll talk for one more minute, is that you have to be able to distinguish between simple clotting of the graft of the fistula versus total access thrombosis. So, and then there it is there. So anyway, I'm done. I talked too long. Sorry, guys. Thank you very much.